lectures and the slides are loaded, so I'm not expecting you to know each and every single detail in the lectures. You need to be, at the end of the lecture, be able to recognize major antibiotic groups that we use in our clinical practice, their major coverage, indications to use, and the most common side effects. So as you all know, antibiotics are agents used against bacteria. Antimicrobials are a more generic term to describe the use of a specific compound targeting, in general, pathogens, whether they were bacteria, viruses, fungi, or parasites. Antiseptic, so antiseptic meaning killing killing organisms on a living thing or a living tissue. For example, before starting any procedure, they say this procedure should be done under antiseptic technique, meaning killing any possible pathogen, for example, on the skin before the procedure is taking place. Disinfectant, in contrary, we use this term when we're talking about objects, okay? Now, the major group of bacteria are divided into gram-positive, gram-negative, and atypical bacteria. When we say atypical bacteria, the structure of the bacteria is not typical for both other groups, gram-positive and gram-negative. Gram stain, so we need, when we want to identify any bacterial growth, when we suspect a bacterial overgrowth, we need to identify the microorganism or the bacteria that we're dealing with, because our treatment has to be directed towards specific bacterial characteristics, okay? The first step into identifying the identity of the bacteria is to identify its gram stain. This tells us whether this bacteria is a gram-positive bacteria or a gram-negative bacteria, okay? So gram staining is using crystal violet stain. So usually gram-positive bacteria, they have a very thick cell wall, and it will uptake the crystal violet stain really well. And when it goes through decolorizing or decolorizing, the color would still stay like violet in color. It will stay stained. This is the opposite when we talk about gram-negative bacteria that has a thinner cell wall, and it's also surrounded by lipid layers. So the uptake of the stain won't be optimal as in the gram-positive stain. So even after we decolorize them, they will end up being colorless or white. And then at the last stage, which is the using of the saccharin stain, the gram-positive would stay still would still look violet, but the gram-negative will look pink in color or red in color. Okay. Two terms which I think you're familiar with from microbiology and pharmacology, right? So pharmacokinetics and pharmacodynamics. When we say pharmacokinetics, it's how our body processes or takes care of the antibiotic in terms of absorption, distribution, metabolism, and excretion. When we say pharmacodynamics, it's how the antibiotic interacts with the pathogen or the bacteria. So this includes whether saying that this antibiotic is bactericidal or bacteriostatic. Do we know the difference between bactericidal and bacteriostatic antibiotics? Sorry? Okay, so killing versus inhibition. Okay. Also, when we say pharmacodynamics, we also mean the minimal inhibitory concentration. Do we know what does this mean? Excellent. So the minimal concentration of the antibiotic needed to عشان لما نطلع على البليت نشوف إنه the growth of the bacteria has been inhibited. Okay. So as we said earlier, antibiotic groups are divided into further many categories according to their mechanism of action and how they kill or inhibit the growth of the bacteria. So we have antibiotics that work on cell wall synthesis inhibition, Others work on protein synthesis inhibition or cell membrane synthesis inhibition. So, and there's subgroups for each major group. We'll start with antibiotics that cause cell wall synthesis inhibition. So the major antibiotic group is the beta-lactams, and this is one of the most commonly used antibiotic. If you go through like patients in the wards, بيطلعوا شو antibiotic that are being used. So most of the patients will have at least, you can find 90% are on one of the beta-lactam groups. They're called beta-lactams because they do have in their structure the beta-lactam ring. So the beta-lactam ring, شايفين الإشي الأحمر? This is the beta-lactam ring. It's composed of 3 carbon ions and 1 nitrogen. Okay? هلا الكربون ion تعمل double bond مع الأكسجين. تمام؟ وهاي البوند هي يعني it gives the major characteristic of the antibiotic, how it works and how it kills the bacteria and how it causes cell wall synthesis inhibition. Okay? So the major beta-lactams, again, antibiotics that have the beta-lactam ring are the penicillins, carbapenems, cephalosporins, and monobactams. Now, beta-lactams in general, they're all considered bactericidal, okay? طيب لو طلعنا هون احنا حكينا انه البيتا-lactam ring فيه ال carbon oxygen double bond اللي هي بتعطي الكاركترستيك والميكانيزم اوف اكشن تاعت الانتيبيوتكس. هلا الميجر thing that you have to take from this slide انه البكتيريا cell wall synthesis فيه زي bonds، اوكي؟ بينهم، اللي شايفينهم هون شايفه واضح البوينتر؟ هدول DALA structure، اوكي؟ هلا هدول if they were disrupted disruption of bonds هدول can happen by many mechanisms. لما نحكي عن beta-lactams that cause cell wall inhibitors, mostly they work on they bind the transpeptidase active site, inhibiting the cell wall synthesis inhibiting هدول البonding to form بالcell wall تاع البكتيريا. Okay. طيب هلا هدول general side effects رح نلاقي انه كل antibiotic side effects تاعته بالسب جروب مختلف عن الثاني، بس in general most beta-lactams they cause hypersensitivity reactions. Anaphylaxis is a big concern when using beta-lactam antibiotics. Non-specific drug-induced skin rash or skin lesions, either immediately forming after the initiation of antibiotic or as a delayed reaction for the antibiotics. Some of them they cause significant bone marrow suppression. Most of which is reversible, so when stopping the offending agent, bone marrow should go back to be functioning normally. Some of them cause interstitial nephritis and GI manifestations. So GI manifestations are not exclusive for the beta-lactam antibiotics. So any prolonged use for broad spectrum antibiotics will cause GI manifestations because it will kill the microbiome or the normal flora of the GI, causing overgrowth of other bacteria like Clostridium difficile, causing chronic GI manifestation, diarrhea, and subsequent malabsorption. Beta-lactams, they don't work against atypical microorganisms. Why is that? And they don't act against MRSA, which is methicillin-resistant Staphylococcus aureus, which is a gram-positive resistant pathogen that causes significant, like severe infections, especially in patients who are immune compromised or admitted to hospitals. Okay, we'll start talking about penicillins. So we have 4 groups of penicillins. We know that the initial or the oldest one, the first generation, has been there for since hundreds of years. They have been used. This includes oral penicillin like PenV or PenG, which is the IV formulation, or the IM, which is the benzathine penicillin. They do have a good coverage against most of the strep species. They are excellent to treat syphilis and most oral anaerobes. As we go down, second generation, so it's a broader spectrum of coverage. We're talking about amino penicillins. So there's an amino group added to the first generation or the main penicillin group. So they are orally amoxicillin or ampicillin as IV formulation. They do have excellent coverage against both gram-positive and gram-negative bacteria. However, they don't cover vancomycin resistant enterococcus. They also do cover Listeria monocytogenes and Group B strep, making them the antibiotics to go when we want to cover early onset neonatal sepsis. صح? When we cover early onset neonatal sepsis, the main organism that we are worried about واللي هم most commonly to cause early onset sepsis, Group B strep. صح? And Listeria specifically, it needs to be covered by ampicillin. Okay? Aminopenicillin are also used sometimes to, theoretically speaking, to cover or to treat urinary tract infections. However, despite that, in vitro, احنا بنحكي لما نعطي antibiotic أو نشرح عن antibiotic إنه في in vitro effect في in vivo effect. In vitro لما تجيب أنت plate على bacteria and you test the antibacterial agent. In vivo, how it works in your body, the actual inhibition inside of your body. Sometimes there might be discrepancy between in vivo and in vitro results. So in vitro, you will be able to maintain good urinary concentration of the antibiotic. Theoretically speaking, it should work, but nowadays most microorganisms causing UTI, they are gaining resistance. Okay, so per se, in general, aminopenicillins are not our first choice to treat UTI. So this is theoretical aspect of the aminopenicillin coverage. They're excellent to cover upper respiratory tract infection like sinusitis and otitis media. They have no coverage over Pseudomonas aeruginosa. Third generation penicillin, we call them anti-staph penicillin. When we say anti-staph, we mean methicillin sensitive staph aureus, not methicillin resistant. So MRSA is not covered by a third generation penicillin. This is a common exam questions, okay? One of the major commonly used third generation penicillins are dicloxacillin, which is a PO formulation, methicillin as IV, and nafcillin, doxycycline are also given as IV formulation. Nafcillin is excellent, specifically when we're treating, for example, septic arthritis or otitis media, where the most common pathogen to cover is MSSA or methicillin sensitive Staphylococcus aureus, and they have excellent safety profile and almost no major side effects. Fourth generation penicillins, we call them anti-pseudomonal penicillin. So they cover Pseudomonas aeruginosa, but هلا رح نحكي عن emergence of resistance and what groups we need to add to penicillins to broaden the spectrum of their coverage. So fourth generation cephalosporins, they have anti-pseudomonal activity. By them we mean penicillin, piperacillin, and ticaracillin. However, in order for you to trust these antibiotics to cover, for example, gram-negative or to cover Pseudomonas, they have to be bound to a beta-lactamase inhibitor group. So, when we add a penicillin to a beta-lactamase inhibitor group, you offer a broader spectrum of coverage. This is number one. Number two, as we said, now there's an emerging resistance and beta-lactamase producer pathogens or bacteria. لما نحكي beta-lactamase, يعني the bacteria has learned its lesson to produce an enzyme which is a beta-lactamase that will lyse a beta-lactam ring, thus will make the antibiotic inactive, so it wouldn't work. عشان هيك صاروا عم بيضيفوا للpenicillin major groups البيتا-lactamase inhibitor. For example, amoxicillin, one of the aminopenicillins اللي حكينا عنهم. If we add to it calvinic acid, it's now co-amoxiclav or co-amoxiclan, co-amoxiclav or amoxiclan, or as it's called, augmentin. So now, because it's now it has the beta-lactamase group, you can trust it to treat. It has a good coverage against gram-negative, gram-positive, and anaerobes. Okay. The same for ampicillin, the second aminopenicillin. If you add sulbactam to it, it now covers excellent. It has excellent coverage against gram-positive, gram-negative, and anaerobic. They are specifically the drug of choice for skin and soft tissue infections, and some occasionally, if the patient is not sick and has never grown any resistant microorganism, we can use them to cover for intra-abdominal infections. However, they don't have Pseudomonas activity. In order to cover for Pseudomonas, you have to add piperacillin, tazobactam, or ticaracillin, calvulinate or carbonic acid. Okay. Now, the piperacillin tazobactam or the ticaracillin, yes, they do have anti-pseudomonal activity, but again, they're not good to cover methicillin-resistant Staphylococcus aureus, and they're not the drug of choice to cover atypical bacteria like Chlamydia or Mycoplasma, and they don't cover for extended spectrum beta-lactamase producing bacteria. The next beta-lactam group is the cephalosporins. So we have 6 generations of cephalosporins. Not all of them are commonly used for so many reasons. One of the reasons, some of them are really expensive, okay? And in countries like Jordan, only the major groups of cephalosporins are being used. So the availability is an issue in our country. The first generation, the cephalosporins, as you go down, we have less gram-positive coverage and more gram-negative. Okay, so first generation cephalosporin, it has good gram-positive coverage, but again, it doesn't cover resistant gram-positive pathogens like MRSA. So if you're talking about methicillin-sensitive Staph aureus or MSSA, this is a good choice to go to, which is first generation cephalosporin. They have do excellent coverage against strep species and some weak activity against major non-resistant gram-negative groups like Proteus, E. coli, or Klebsiella. They are good to treat cellulitis. Cefazorin in specific is given IV as preoperative prophylaxis. Second generation, this is one of the very widely used cephalosporin because it comes in 3 formulations, IV, oral, and IM, which gives the clinician flexibility to be used inpatient as well as outpatient treatment. They do have cover somehow broad coverage against gram-positive, gram-negative, and they also are excellent choice for respiratory infections. Other second generation like cefoxitin, which is given as IV, we go for this antibiotic if we need to cover for anaerobic infection, like for when we suspect intra-abdominal infection caused, for example, by bacteroides, which are our gram-negatives. However, they don't have anti-pseudomonal coverage or don't have good gram-positive coverage. Third generation cephalosporin أكيد من أكثر الأنتيبيوتكس تسمعوا فيها بالراوند صح؟ ceftriaxone and cefotaxime, which are constant broad-spectrum antibiotics. They have excellent gram-negative coverage. They do have excellent gram-positive coverage. They are the drug of choice to treat meningitis, pneumonia, and UTI. Again, they don't have anti-pseudomonal coverage or activity, and they don't cover anaerobes. Fourth generation in specific cefepime, this is anti-pseudomonal. So if you want cephalosporin to cover for pseudomonal infection, cefepime is an excellent choice. However, this only comes with IV formulation, so the patient has to be treated as inpatient. Fifth generation, like ceftaroline, they do have very broad spectrum coverage, gram-positive, including methicillin-resistant Staph aureus, MRSA, and Pseudomonas aeruginosa, amongst gram-negative covered by ceftaroline. Sixth generation, we don't use it commonly in pediatrics, and it has a black box warning. It's not to be used in kids below 18 years of age. Carbapenems, they're called the most broad-spectrum antibiotics. Carbapenems, they have excellent coverage for gram-negative, gram-positive, and anaerobes. Also, they do cover Pseudomonas except ertapenem. So we have imipenem, meropenem, ertapenem, and doripenem. They all do cover Pseudomonas except ertapenem. Again, this is a very common exam question. They have excellent CNS penetration, thus making them a good choice for meningitis and encephalitis. ESBL. So لما نحكي حكينا ESBL means extended spectrum beta lactamase producing bacteria. Now ESBLs لما نحكي which bacteria is ESBL positive, which bacteria is negative. So ESBL negative or positive, we mean the Enterobacteriaceae family. So مش معنى نحكي عن كل gram negative، نحكي عن subgroup of the gram negative bacteria. مثال عليها الكلابسيلا، الإيكولاي، البروتيوس، سالمونيلا، شيجيلا، يرسينيا، سيريشيا ماركيسنس، etc. زي ما حكينا they produce beta lactamase. So most of beta-lactams won't work to cover ESBL positives. So the drug of choice would be carbapenems. Okay. Monobactams, they only have a very narrow coverage against gram-negative anaerobes like Pseudomonas. They don't have any activity against gram-positive pathogens. Glycopeptides, we have one glycopeptide antibiotic which is vancomycin. Vancomycin, زي ما شرحنا قبل, it binds the, or it's a mimicker for the DLA portion of the cell wall تاع البكتيريا. It inhibits cell wall synthesis. It has a very wide spectrum against gram-positive bacteria, including medicine-resistant Staph aureus. So it's given in the IV route, except in one indication. We can give it as oral, اللي هو when we want to cover Clostridium difficile infection. تمام? That's the only indication to give vancomycin as oral route. يعني الفايل بتنعطى IV بتنفتح والمريض بيشربها. This is the only indication where we give it as per os or per oral. طبعا vancomycin is a very potent antibiotics, and we describe it as one of the big guns. So we don't add vancomycin for like any patient. تمام؟ لازم يكون في specific indications. Mainly specific indication, for example, if you have a patient who's admitted with pneumonia, let's say, if the patient is very sick, if the patient is hypertensive, needs inotropes to manage, we need vancomycin because now we're suspecting that this pneumonia is caused by a resistant microorganism or resistant strep. Okay, for example. If you want to treat someone with meningitis, you give the patient the benefit of doubt. So you assume that the most common cause of meningitis? Bacterial. Strep pneumo, right? So strep pneumo. أكيد. شيماء. example, the most common cause of bacterial meningitis. تمام؟ هلا احنا انه مريض النمونيا, the management of a pneumonia patient, assuming انه the most common cause of bacterial pneumonia is strep pneumo, we start with a broad spectrum antibiotic like ceftriaxone, a third generation cephalosporin that has a good coverage against gram-negative and gram-positive. And if the patient does not respond, if the patient deteriorates, if the patient is sick, hypotensive, حكينا we add vancomycin. In treating patients with pathologies like in meningitis, you give the patient the benefit of doubt. So you assume that the meningitis caused by a resistant strep pneumo species. So you don't wait for improvement or deterioration. You don't wait for the patient to show signs of poor response to start vancomycin. So we immediately when you suspect meningitis, when the CSF analysis is positive, you start the patient on ceftriaxone and vancomycin. Okay? So again, vancomycin has to be used in caution and in specific indications. لأنه هلا صار في عندنا emergence of vancomycin resistance enterococci or enterococcus, which is a disaster. Okay? Vancomycin is one of the known nephrotoxic medications. So a patient on vancomycin has to be very well hydrated. If the patient has any vomiting or sensible and insensible losses, you have to make sure that they are maintained on IV fluids. You have to do kidney function tests to make sure that kidney function is okay, at least twice weekly. There's what we call the trough vancomycin level. So obtaining a blood sample to check for the vancomycin level just before the next dose. نسميه احنا trough level to check if the patient is on a decent dose of the antibiotics. One of the common problems with vancomycin is what we call the red man syndrome. It's not a type of allergy. So if someone develops vancomycin, ما نحكي عنه this patient is allergic to vancomycin. It's a phenomenon has to do with sudden histamine release, okay? But it's not allergy. Usually it's caused by rapid infusion. So vancomycin, when it's given in rapid infusion, this causes rapid mast cell degranulation and histamine release, okay? So if anyone develops Red-Man syndrome, this is not a contraindication to give subsequent doses, but we give instruction to the nurses that the drip or the infusion has to go really slow, and sometimes we need to pre-medicate the patient with antihistamines before the dose of vancomycin. This is how Red-Man syndrome looks. It mimics drug reactions that we see with other drug groups like penicillins. Bacitracin antibiotic, it's one of the bactericidal antibiotics. The use of it is limited as topical for skin or eye infection. Okay. Daptomycin. So daptomycin, هلا قبل شوي حكينا عن emergence of vancomycin resistant enterococci. So the only antibiotic then that you can give is vancomycin, daptomycin. So daptomycin, it disrupts the cytoplasmic membrane of gram-positive microorganisms like methicillin resistance, Staph aureus, or vancomycin resistant enterococci. It's given as IV route, but we can't use it below the age of 2. Major side effect, rhabdomyolysis, elevation of CK, and thus you need to strictly monitor kidney function test and urine output. Okay, so antibiotics that inhibit protein synthesis, they are usually bacteriostatic with one exception, which is the quinolone group, which are bactericidal. Can be bactericidal according to the dose and concentration. The first group of that we're going to talk about with regards to bacteriostatic. So the first group that we're going to talk about, which is the protein synthesis inhibitor group, which is the trimethoprim sulfamethoxazole, or what we call it, or as it's called, Bactrim. Okay, it works on inhibition of folate. Definitely, folate is very important for the DNA synthesis in the cell cycle. Okay, major side effects of sulfonamides, bone marrow suppression, and hemolytic crisis in patients with G6PD deficiency. So دائما أي مريض G6PD بنعطى like a leaflet on things to avoid, including Bactrim or any medication that has sulfa group. Okay. Bactrim has an excellent coverage against methicillin-resistant Staph aureus. So if you want to treat MRSA as outpatient, Bactrim is a drug of choice. Sometimes it's a continuation for IV treatment. So if the patient is treated, for example, for osteomyelitis, culture tag, kind of Staph aureus MRSA, and the patient has received, for example, 4 weeks of IV vancomycin, then you can discharge the patient on Bactrim as it has excellent MRSA coverage. However, even though it covers gram-positive microorganisms like Staph aureus, it's not the drug of choice to cover strep species, for example. Okay, fluoroquinolones, as we say, they are an exception to protein synthesis inhibitors. So they do act as bactericidal in specific doses and specific concentrations. Protein synthesis. Yes. هاي السلايد.
الفولات والدي ان اي كلهم نعتبرهم برضه من ضمن البروتين.
طيب. هلا البروتين synthesis or DNA synthesis, it happens through different mechanisms. So, for example, some antibiotics, they work on the 30S ribosome inhibition. They do inhibit DNA, صح? And protein. The 50S, some antibiotics, they work on the 50S ribosome inhibition. The same mechanism, okay? So they target different aspects of DNA synthesis, okay? Or protein synthesis. طيب هدول صراحة هدول too complex for you, even for my level. يعني they're too complex. I don't have complete understanding, for example, for this figure.
كنت بس بعرف
Okay.
البروتين انه
Yes, زي ما قلنا البروتين there's multiple mechanisms to inhibit, either working or inhibiting the 30S ribosome or 50S ribosome. كلهم اسمهم protein inhibitors.
بدي يعني اوصل الفولات من ضمنهم يعني مثلهم.
Yes, وفي شيء مثلا acts on the DNA gyrase. This is another mechanism to inhibit DNA synthesis. Yes. Okay. هلا quinolones, this is a very interesting group of antibiotics. ليش؟ لأنه ال subgroups بالquinolone, each of them has its own mechanism of action and يعني their coverage is different. For example, one of the most commonly used fluoroquinolone is profloxacin. تمام؟ Ciprofloxacin, it has an excellent gram-negative coverage and it also has an excellent pseudomonal coverage. If you but it has no gram-positive coverage. If you compare it with levofloxacin, the next group of fluoroquinolone, they do have cover gram-positive. So they are same major group, fluoroquinolone, but the coverage is totally different. تمام? So if I want to cover pseudomonas, if I want to look for an oral agent to cover pseudomonas, I choose ciprofloxacin, I don't choose levofloxacin. If I want to cover gram-positive respiratory, for someone who has respiratory infection, we know that most common microorganisms بتعمل respiratory infection upper and lower هي gram-positive مش gram-negative. In immune-competent احنا عم نحكي. So if I want to target gram-positive respiratory infection, I don't go for ciprofloxacin. I go, for example, for levofloxacin. That's why it's called a respiratory quinolone. Okay. So even though they are under the major category fluoroquinolone, the mechanism of action and the coverage is totally different. For example, levofloxacin, not only they do cover gram-positive, their anti-pseudomonal coverage is very weak. So if I want to start a patient on anti-pseudomonal, I don't go for levofloxacin. I go for Cipro. تمام? Moxifloxacin, again, it's a respiratory quinolone, so it covers gram-positive microorganisms commonly used causing respiratory infection. Now, with moxifloxacin, now there are studies that احنا نعرف إنه tuberculosis management هي a combination of 3 or 4 mycobacteria, صح? Recent studies show that if you take one of those antibiotics replaced by moxifloxacin, the outcome is much better and the duration of treatment will be shortened. Okay, هدول studies mainly on adults, مش pediatrics, but nowadays they're strongly suggesting replacing one of the combination antimicrobacterial with moxifloxacin. طيب. inhibition of the DNA by inhibiting the RNA. يعني DNA dependent RNA polymerase inhibition. So this is again another way to inhibit DNA synthesis. Okay. The drug that we're going to talk about is rifampicin. It's one of the commonly used medication against Mycobacterium tuberculosis. One of the combination I use as combination, not as a mono drug, and it's used for chemoprophylaxis. شو يعني chemical prophylaxis or chemoprophylaxis? بأي حالات؟
الأشخاص اللي بياخدوا كيموثيرابي نعطيهم بروفيلاكس
لا هو اسمه كيموبروفيلاكسي بس ما له دخل بالكيموثيرابي.
لما يكون حدا عامل كونتاكت مع حدا عنده تي بي.
ها؟
لما الواحد يكون عامل كونتاكت مع حدا عنده تي بي.
لا هلا حدا جاوب؟ حدا بحب يجاوب؟
بس حماية يعني.
طيب.
كل حدا عنده ريسك للتي بي.
هي ما لهاش دخل بالتي بي. اوكي ولا بالكيموثيرابي. هلا المرضى اللي بصير في عندهم meningitis او بكتيريا meningitis وبيكون الكوز Neisseria meningitis or Haemophilus influenza. You need to give chemoprophylaxis for close contacts or household contacts. تمام؟ أخذتوا محاضرة المننجايتس؟ موجودة بالمحاضرة صح؟ شرحناها. So rifampicin is one of the chemoprophylactic antibiotics given to patients with meningitis that we suspect they're having Neisseria meningitis or Haemophilus meningitis for the patient himself and the household close contacts in the past, for example, 72 hours. To decolonize them, لأنه هدول البكتيريا can be a colonizer بالrespiratory tract. Okay? Again, another use for rifampicin. شو اليوزز تبعهم؟ نعيدهم لأنهم برضه one of the common examples نسأل عن الريفامبين. لأنه أول شيء it's used for TB, so this is not a common يعني coverage for other antibacterial agents. So for mycobacterial tuberculosis treatment as chemical prophylaxis, and if you want to treat Staph aureus related biofilm. إيش يعني biofilm؟
colonization مايكروب كثير
على foreign body inside the body، صح؟ الناس اللي عندهم plate for example مركبين مثلا pacemaker صار عندهم staphylococcus infection، هدول at a very high risk to develop a biofilm. If a biofilm develops, given anti-staph antibiotic won't work unless you add rifampicin as a biofilm inhibitor, okay? One of the major side effects for rifampicin is orange body secretions. Yani for example, the urine would be orange in color. And this is transient. When you stop rifampicin, things should go back to normal. Okay. Nitrofurantoin, again, it inhibits the RNA with DNA polymerization. Okay? It's one of the bactericidal antibiotics. It's an excellent choice, specifically in female, to cover for UTI, urinary tract infection caused by major non-resistant gram-negative like E. coli, Klebsiella, Enterobacter, etc. Major side effect with nitrofurantoin, pneumonitis, and pulmonary fibrosis, which is irreversible. Okay? Absolute contraindication to give nitrofurantoin is renal failure or decreased glomerular filtration rate. Metronidazole, they work on the protein electron transport channel, and this is very important when you want to disrupt DNA in anaerobic bacteria, disrupt DNA synthesis. So it's bactericidal. We use it to cover for anaerobic microorganism or anaerobic infection, like for example abscesses. When we talk about lung abscess, brain abscess, some intra-abdominal infection or abscesses. It's a drug of choice for anaerobic infection as well. Okay, protein synthesis inhibition by inhibiting the messenger RNA that binds to ribosomes. So هاي النقطة إنه protein synthesis happens in so many ways. تمام؟ طيب حكينا في antibiotic that inhibits the 30S ribosome group. Other antibiotics they inhibit the 50S ribosome بيعمل 50S ribosome inhibition. طيب. One of the common 30S ribosomal subunit inhibitor هم tetracyclines. Tetracycline is a big group. فيه tetracycline as an antibiotic, doxycycline and minocycline. We don't like to use tetracycline in pediatric age group because of the unsafe profile, and they do have significant side effects. Okay, like photosensitivity, hepatotoxicity, they're teratogenic in pregnant women. They cause significant GI upset, teeth discoloration, and biliary stasis. They're absolutely contraindicated to use in kids below 8 years of age due to their permanent discoloration of teeth. The indication to use tetracycline اللي هي some gram-negative infections, for example like rickettsia rickettsii. It's also used to cover tropical infections like Lyme disease. It has some coverage against MRSA, however it's not a trusted coverage. So if the patient is sick, you don't go for tetracycline to cover for methicillin-resistant Staphylococcus aureus. They do have weaker, less broad-spectrum coverage against gram-positive and gram-negative bacteria. Aminoglycosides are amongst antibiotics that inhibit 30S subunit, ribosomal subunit. Examples on aminoglycoside: gentamicin, tobramycin, amikacin, and streptomycin. They do have, again, unsafe nephrotoxic or unsafe profile when it comes to nephrotoxicity and ototoxicity. So patient with or patient on aminoglycoside has to have regular kidney function tests, and they need to have excellent hydration status, and they need sometimes to undergo hearing assessment after ending or finishing a course of treatment. They do have coverage against gram-negative bacteria like Pseudomonas antibiotics. Sometimes so either we use them to cover gram-negative organisms like Pseudomonas, or if you want to add a synergistic effect when you are covering gram-positive bacteria. So they're not used as monotherapy to cover gram-positive. Again, this is a common exam question. So amaloglycoside, yes, we added to cover gram-positive, but as a synergistic effect, not as monotherapy. Macrolides. This is one of the very, it's one of our pediatricians' most used or favorable antibiotic to use for so many reasons. أولاً, it's very safe. It has an excellent safety profile. ثانياً, it's given as PO route. The taste is good, is okay. So هذا الشيء هاي نقطة كتير مهمة when you come to pediatric age group. They have to taste well antibiotic. For example, it's a nightmare to prescribe oral clindamycin for a kid. It's very bitter and they can never tolerate it. Okay? So azithromycin or macrolides in general, they do have good taste, and they most importantly use as 1 per day dose. So that you won't have significant compliance issue. In medication that you have to use 3 or 4 times a day, you will come across a significant compliance issue. So you have to wake the kid in the middle of the night to have the antibiotic dose. You have to give them antibiotic dose before going to school or during school hours. So it's a hassle sometimes to prescribe antibiotics given as Q6 or Q4 dosage. With macrolides, it's only 1 per day dose. Significant side effects that you have to be vigilant about: QT prolongation and significant GI upset. Besides their use as antimicrobials, they are used as prokinetic. إيش يعني prokinetic? To increase the GI motility to enhance gastric emptying. Okay? Their antibacterial coverage, they are the drug of choice to cover atypical microorganisms, زي Mycoplasma pneumonia, Chlamydia pneumonia, or Legionella. Okay? They do have a decent gram-positive and a gram-negative. So they're somehow considered an oral broad-spectrum antibiotic. So good gram-positive, good gram-negative, excellent for upper respiratory tract infection, excellent for otitis media coverage, excellent for pneumonia and atypical pneumonia. Okay? Clindamycin, it's one of the 50S ribosomal subunit inhibitor. Clindamycin, as I said, it's one of the medications that has to be used in caution, and it has a limited use in general. So one of the common indications for clindamycin is being an oral option for MRSA or methicillin-resistant Staphylococcus aureus. They do have good somehow anaerobic coverage, good gram-positive coverage, including strep and resistant Staph aureus. They're the drug of choice to treat cellulitis and necrotizing fasciitis, and they exert an antitoxin effect. So بحالة toxic shock syndrome, for example, you add clindamycin. So again, they're not used as monotherapy. You add them as antitoxin medication because they decrease the toxin formation. They have very poor CNS penetration, so they're not to be used in case of, for example, meningitis or encephalitis. Chloramphenicol. Nowadays, in the past, like tens or hundreds of years ago, it was one of the most commonly used antibiotic, specifically to treat cases like meningitis. Now it has a very limited use due to its unsafe profile and significant side effects. One of the serious side effect is the idiosyncratic reaction, which is an irreversible bone marrow suppression. And they cause complete shutdown or aplasia in the bone marrow, and this is irreversible even after you stop الantibiotic. تمام؟ هلا so in pediatric age group, the use of chloramphenicol is very limited. We use it only as topical treatment for as an ointment. Okay? Linozolid. Linozolid is like one of, again, the excellent antibiotics to cover gram-positive organisms. And شو ليش في use مهم للينوزوليد؟ and methicillin resistant staph aureus والstreptococcus. اوكي طيب هلا في شيء اسمه serotonin syndrome صراحة I have never seen it. I think it's read just in books. It's good to read about it بس مش شيء مهم نعرفه. serotonin syndrome. Linozolid can cause bone suppression, but this is reversible. So after you stop the antibiotic, things should go back to normal. Some peripheral neuropathy is documented in adult age group. I don't recall peripheral neuropathy in pediatric age group. And one of the drawbacks on linozolid that it's very expensive. طيب هدول هم repetition أو recategorization of everything that we have just said. Okay? So you can go back and read on your own. هم بس بنحفظوا حفظ يعني شو هم الانتي من كل اللكتشر اللي حكيناها شو هم مثلا انتي MRSA شو هم اعطوني هيك مثال متاكد انكم صحيين. vancomycin linozolid حكينا linozolid شو كمان لا clindamycin شو كمان daptomycin VRE excellent. اوكي سو هذا بس brainstorming عشان يعني recategorization عشان تكونوا عارفين يعني for each microorganism which antibiotic to go for. It's not يعني for infection أو مش for clinical understanding. اوكي يعني بدك تكون عارف إنه يعني معلومات جامدة. staff MRSA شو نعمل staff MSSA which antibiotic مثلا MSSA شو antibiotic that we go for. What generation of penicillin? Third generation, excellent.